Electromechanical coupling throughout the cardiac cycle. In the heart, the electrical events are rapid, and the mechanical events are much slower. So, mechanical events will always lag significantly behind electrical events. Consider atrial contraction. The sequence of events is the sinoatrial pacemaker cells spontaneously develop sinoatrial node depolarization, and this spreads. A millisecond or two later, the depolarization spreads into the atria to give the onset of an electrical P wave. The P wave represents electrical depolarization of the atria, and the resulting mechanical contraction must occur slightly later. But as the atrial muscle mass is small and conduction speeds are fast, the mechanical atrial systole occurs very soon after the start of the P wave. For the atria, they spend most of the cardiac cycle in mechanical relaxation, except for about the last 10 to 20% of diastole, when atrial contraction transports blood into the ventricle just for the very last 50 or so milliseconds before ventricular electrical systole commences. This is the atria turbocharging the ventricle and is termed atrial transport. Now, in atrial fibrillation, there is no coordinated mechanical contraction, and after electrical cardioversion and resumption of sinus rhythm, there is often a period of electromechanical dissociation which may last several days. And this is an example of electromechanical uncoupling. Now let's talk about ventricular contraction. Mechanical ventricular systole commences at the peak of the QRS complex, and mechanical ventricular diastole is over at the time of the peak of the subsequent T wave. So in health, the ejected stroke volume commences 30 to 40 milliseconds after the start of the QRS, and it is finished by the T wave peak. To be precise, ventricular electrical depolarization may actually commence with a Q wave, an R wave, or its reciprocal, the S wave. In a lead with an R wave, which is by definition the upstroke of the QRS complex, the R wave represents the depolarization of the first group of ventricular myocytes, and the QR interval, which is the upstroke, defines the interval called the ventricular activation time. The S wave is the first downstroke of the QRS complex and is the depolarization of the remaining group of ventricular myocytes. This downstroke defines the end of the interval called the QRS duration. Mechanically, the phase of isometric ventricular contraction occurs from the peak of the QRS to the peak of the T wave and is synchronous with closure of the mitral and tricuspid valves, causing the first heart sound. The peak of the mechanical contraction of the left ventricle occurs on the ascending limb of the T wave, and by the peak of the T wave, the left ventricle has begun its isometric relaxation, and its pressures are decreasing rapidly. So, the early part of the downstroke of the T wave represents isotonic ventricular relaxation. Now, if we also have a peripheral arterial line in place, such as at the radial artery, we must be aware that by the time the pressure pulse peaks in the radial artery, it is delayed by at least 30-40 milliseconds after the opening of the aortic valve. Electrical ventricular diastole commences with the onset of the T wave, but mechanical ventricular diastole does not actually commence until the downslope of the T wave. The incisura on the descending limb of the arterial line defines retrograde central aortic blood flow hitting the aortic valve, and so the incisura must occur just after the onset of isometric relaxation. And this occurs simultaneously with forceful closure of the aortic and pulmonic valves, causing a normal second heart sound. The very early part of the decreasing diastolic blood pressure just after the incisura occurs on the descending limb of the T wave. The basis of electromechanical coupling in heart muscle depends on ventricular depolarization acting on the T-tubule and sarcoplasmic reticulum system and releasing a pulse of free intracytoplasmic calcium, which initiates actin and myosin and tropomyosin conformational changes, which allow the sliding filament mechanism to generate mechanical contraction. Conversely, repolarization promotes uptake of cytoplasmic calcium and ventricular muscle starts to relax. This elegant biochemical system requires a constant supply of energy to function, even in diastole, and can be impaired or even totally inactivated in certain biochemical circumstances within the cell, and this is known as electromechanical dissociation or uncoupling. Causes of electromechanical dissociation are these. There are physiological and electrolyte causes, and these are severe acidosis, severe hyperkalemia or severe hypokalemia, and severe hypocalcemia. It can also occur in severe myocardial ischemia, myocardial infarction, and even in myocarditis. It may occur with overdose of the following medications: some cardiotoxic antidepressants, beta blockers, calcium channel blockers, and digoxin overdose. All of these overdoses can cause electromechanical dissociation, leading to a clinical syndrome called pulseless electrical activity. Remember the mnemonic ABCD: antidepressants, beta blockers, calcium channel blockers, and digoxin overdose. Currently, the term electromechanical dissociation is best reserved to refer to the absence of electromechanical coupling at a cellular level. In the past, for example, when I was training in anesthesia, the term electromechanical dissociation was used to refer to cardiac activity in the absence of a peripheral pulse. But this clinical situation is now more appropriately termed, again, pulseless electrical activity. Electromechanical coupling, that is, all electrical and mechanical activities of the heart other than cellular repair, are responsible for the vast majority of cardiac oxygen demands and metabolic demands for substrate. And this is a good opportunity to consider cardiac metabolic demands. So in the next presentation, we will consider ventricular metabolism. The ventricles account for the overwhelming majority of oxygen demands of the heart. At rest, basal myocardial metabolic requirements are modest. Myocardium can consume free fatty acids, glucose, and lactate as its major source of energy, although the brain has priority over the glucose. The heart can also resort to amino acids and ketones. The importance of ketones increases in starvation states and during endurance sports events. The metabolism of all this requires an abundant supply of oxygen. If myocardium is alive, it has an oxygen demand, of course, in diastole as well as systole. Myocardial food substrate and oxygen demands increase with exercise. Limitation of food substrate is rarely a clinical issue, but myocardial oxygen demand is frequently a concern in the hospital population of patients. Myocardial oxygen supply depends on arterial blood containing an adequate level of hemoglobin, an adequate oxygen saturation, adequate diastolic coronary artery blood pressure, and blood flow. Now, let's consider the determinants of myocardial oxygen demand. Electrical depolarization of the heart accounts for only about 0.5% of metabolic demands, but it is mechanical contraction of the heart which generates most of the demand. It represents 99% of metabolic demands. Now, consider a healthy individual at rest with a heart rate of 72 beats per minute. As heart rate and contractility increase, myocardial oxygen demands increase. And these are the two most obvious determinants of myocardial oxygen demand. Increased velocity of myocardial contraction is an approximate index of contractility. Also, it is intuitive that as the tension in the wall of the ventricles increases in systole, what we call afterload, the metabolic oxygen demands must increase also. Increases in systolic arterial blood pressure increase afterload dramatically. What is not so obvious is that the ventricular myocardial oxygen demands may increase significantly above resting levels in disorders which increase ventricular wall tension in diastole, which is the very definition of preload. This situation occurs in diastolic dysfunction, so ventricular myocardial oxygen demands can be a concern in both diastole and systole. An estimate of cardiac work is the change in volume of the left ventricle in systole times the change in ventricular cavity pressure in systole. This is delta V by delta P. This is an approximate estimate of how much work the ventricle is doing. So now consider this animal experiment. We can double the cardiac work by either doubling the delta V or the delta P. We can increase cardiac work by doubling the volume pumped, but the blood pressures are held reasonably constant. So we have increased cardiac work. If cardiac work is doubled by keeping the volume pumped constant, but this time the pressure gradient is doubled, the increase in cardiac work is doubled, but the increase in myocardial oxygen demand is very dramatically increased. The myocardial oxygen demands are almost double the increase seen in volume pumping. So the heart is very efficient at volume pumping. It is designed as a volume pump, and during our evolution, hypertension was probably a very rare condition. But if we double cardiac work by keeping volume constant and doubling the afterload, that is pressure pumping, then the additional oxygen demands compared to volume pumping are alarmingly raised. The point is that our heart was never designed to be a very high pressure pump. It was designed to be primarily a volume pump across a modest increase in pressure range. And why is this? Well, increased pressure work dramatically prolongs the isometric phase. Increased volume work increases the isotonic phase. Isometric work is harder and more demanding on oxygen consumption than isotonic work. Myocardial oxygen demand is proportional to heart rate, systolic and diastolic wall tension, and contractility. Systolic wall tension equates with afterload, which in the absence of aortic stenosis equates to systolic blood pressure. In terms of myocardial oxygen demands, ventricular pressure work is much more demanding than flow work. For example, and these figures are purely for illustration, an approximate 20% increase in afterload generates higher cardiac work and oxygen demand than a 20% increase in preload. A 20% increase in afterload generates higher oxygen demands than a 20% increase in heart rate. But of course, this is an unfair comparison because increases in heart rate are a double-edged sword. The left ventricle is only perfused in diastole, so increases in heart rate occur at the expense of a shorter diastole, which decreases diastolic oxygen delivery. Clinically, there are situations such as severe coronary artery disease where a 20% increase in heart rate may be less well tolerated than a 20% increase in afterload, but these tend to be exceptions to the rule. After ventricular systole, in diastole, A protein called titin attaches to actin. This shortens actin's spring length and increases its resistance to stretch during active stretching of muscles, so preventing overstretching of sarcomeres and the development of excessive sarcomere length. Failure of this mechanism can lead to overstretch of the sarcomeres, with increased diastolic wall tension, preload, and ventricular myocardial oxygen demands. This can present as diastolic heart failure, which in the worst case scenario can precipitate clinical heart failure with a preserved ejection fraction. Much of the work of the cardiologist, the anesthesiologist, and the intensivist in patients with significant coronary artery disease is the manipulation of patients' hemodynamics to minimize cardiac work and oxygen demands while keeping cardiac output and mean arterial blood pressure optimized. This approach of optimizing hemodynamics while minimizing myocardial oxygen demands and increasing myocardial oxygen supply is a common theme we will touch on in the clinical videos you will see subsequently. Thank you for watching.